Record it, because why not? And let me share my screen. All right, so final unit of the class, we're going to start with the pelvis. And of course, the pelvis is what anchors the lower limb to the axial skeleton. So then we will continue from the pelvis down into the lower limb, all the way down to the feet. So we've already talked about the pelvis a little bit before when we were talking about the abdomen, but I want to go over it again. Some of the stuff will be repetitive. I will go into a few things in more detail. So remember that the entire pelvis is made up of two halves. So there are left and right bones, which are sometimes called the os coxa or the innominate bone. Each of those in turn comprises three separate bones that fuse around the time of puberty. So the largest of these is the ilium. That also forms something called the sacroiliac joint with the sacrum. This is by far the largest of the three and includes the whole iliac crest and this big bowl-shaped area where we find the iliacus muscle. And ilium also contributes to the upper part of the acetabulum. Then anteriorly in the pelvis, we have the pubis or pubic bone, highlighted here in red. And you see that it has two bars. I haven't named these, and I don't think these are on your required structures list. In fact, I may not have posted the required structures list for this exam yet, but I'll have to remember to do that soon. But there's a superior ramus of the pubic bone, which is this upper bar, and then an inferior ramus is the lower bar, and then the two pubic bones themselves are united at the pubic symphysis. And then the third bone that contributes to each half of the pelvis is the ischium. This makes up the most inferior bone of the pelvis. So this would be the part that you sit on when you're sitting on a chair. Also makes up the lower part of the acetabulum. Now, something that I don't think I mentioned to you when we were talking about the pelvis in the context of the abdomen are these two large round foramina that sit between the pubis and the ischium. This is known as the obturator foramen. We did learn about a nerve called the obturator nerve, which goes through this foramen. But we didn't actually talk about the foramen itself when we were talking about these bones. So there are these large round foramina that are bounded by the superior and inferior ramus of the pubic bone, as well as the ischium posteriorly. It turns out in the living person, most of that obturator foramen is covered with a membrane called the obturator membrane. So it's not a great big hole that large structures pass through. Most of it is completely filled with this membrane. And not only is there a membrane occupying that opening, but there's a muscle that originates from the inner surface of that membrane called the obturator internus muscle. There's another muscle that originates from the outer surface of that membrane called the obturator externus muscle. So you've got a thick membrane and two muscles originating from that membrane, almost completely filling that foramen. There is, however, a small canal through that membrane, and there are a few very small structures that pass through there. The obturator nerve that we saw in the previous unit is one of the structures that passes through there. There's also an obturator artery and vein that pass through there as well. But I think a lot of people have this impression that there's some giant thing like the psoas muscle or something that passes through this big foramen. But remember, it's really just a tiny canal. That's all that's left. All right, looking in a little more detail at each innominate bone or each half of the pelvis. Here on the left, we're looking at a lateral view. And over here on the right, we're looking at a medial view as if we were inside the pelvis looking out. And again, you see the three major bones, the ilium, the largest of the three, making up the upper part of the acetabulum, pubis, the smallest of the three, making up the anterior-most part of the pelvis, including the anterior part of the acetabulum, and the ischium, which is the most inferior of the three bones, making up the sort of posterior part of the acetabulum and sitting most inferiorly of all three bones. Some landmarks on all these bones, some of which we've also talked about before, which you've got the iliac crest that runs all the way from the front to back along the upper border of the ilium, a pair of spines anteriorly the anterior superior iliac spine, which will turn out to be the origin for at least one muscle in the thigh, as well as the attachment point for something like the inguinal ligament. There's an anterior inferior iliac spine, a little bit lower. This is also the origin for one muscle in the thigh, which we'll talk about later. The pubic bone has the pubic symphysis that we've already talked about. So that's a cartilaginous joint that unites the two pubic bones. Pubic tubercle we've talked about before too. This forms one of the attachments points for the inguinal ligament. Something I don't think we've talked about before, though, is the pectinate line, or sometimes called pectineal line, which is just a little ridge, a little crest on the superior ramus of the pubic bone. This has a couple of different significances. We'll talk about this more a little bit later today. We'll also come back to it when we discuss the muscles of the thigh, because there's a muscle in the anterior thigh that has part of its origin on that pectineal line. If you follow the pectineal line or pectinate line posteriorly, you see that it's continuous with a similar sort of ridge on the inner surface of the ilium. This is known as the arcuate line, and we'll come back and talk about the significance of that as well in a few minutes. Some landmarks on the ischium, looking over here on the left-hand side, there's something called the ischial spine. And that ischial spine creates a boundary between two deep notches on the posterior aspect of the pelvis. There's a greater sciatic notch, which is simply a deeper notch that lies superior to the ischial spine. And then there's a somewhat smaller, shallower notch called the lesser sciatic notch that lies inferior to that ischial spine. All right. And one last landmark on the ischium is the ischial tuberosity. Ischial tuberosity is a very large, thick part of the bone. It's very, very lumpy. The lumpiness comes from the fact that there's a whole lot of muscles that originate on that ischial spine. All of the hamstring muscles have their origin on that ischial tuberosity. These are muscles in the posterior thigh. Here's that same lateral view of one half of the pelvis, but now with the lumbar vertebrae visible as well as the sacrum. And this Netter painting also includes a number of ligaments that are important parts of the structure of the pelvis. So first of all, looking at that obturator foramen, you'll notice what I was talking about earlier, the fact that most of that obturator foramen is filled in with this fibrous membrane called the obturator membrane. And that leaves only a very small canal, the obturator canal, for structures to pass through. So the obturator nerve, artery, and vein are passing through that small canal. But there's actually a muscle that originates both on the inner surface and on the outer surface of this obturator foramen. Notice that there are a couple of large ligaments that anchor the sacrum to different parts of the ischium. There's a ligament that's partly hidden here, but you can make out just a little bit of it, called the sacrospinous ligament. That sacrospinous ligament is connecting the edge of the sacrum to the tip of the ischial spine. And then there's a larger sacrotuberous ligament that connects the edge of the sacrum to that large ischial tuberosity. These ligaments are combined with those two notches that we talked about on the posterior surface of the pelvis, the greater sciatic notch and lesser sciatic notch. When you add these ligaments, they help to define those notches as completely enclosed foramina. So remember that superior to the ischial spine was something called the greater sciatic notch. When you then add the sacrospinous ligament and sacrotuberous ligaments, they completely enclose that as a space called the greater sciatic foramen. So the greater sciatic notch is simply the groove or the indentation on the back of the bones. But then when you add these different ligaments to it, it becomes a completely enclosed greater sciatic foramen. That greater sciatic foramen is going to come up a lot over the next couple of lectures, because there are a whole bunch of really important structures inside the pelvic cavity that are actually leaving the pelvis into the gluteal area. So sometime after break, we'll be dissecting the gluteal area, so the butt, basically. And when we get deep down under the gluteus maximus muscle and get deep into the gluteal dissection, we'll see that there are a whole bunch of structures that originate inside the pelvic cavity, but then are leaving the pelvic cavity and entering that gluteal region through that greater sciatic foramen.
You said that it's created by the sacrotuberous and the sacrospinous ligaments?
Yeah, so if you combine the notch, which is just in the bones, the greater sciatic notch, then when you add the sacrospinous and sacrotuberous ligaments, that completely encloses it as a foramen.
Thank you.
Okay. Same thing with the lesser sciatic notch. The lesser sciatic notch is just a little indent on the posterior aspect of the ischium, but when you add the sacrospinous and sacrotuberous ligaments to it, it becomes a completely enclosed foramen called the lesser sciatic foramen. There are also structures that are passing through that foramen between the gluteal region and the inside of the pelvic cavity, although not nearly as much stuff passing through there as there is through the greater sciatic foramen. You can see those same ligaments here as well as the foramina in an anterior view. So once again, we've got sacrospinous ligament connecting the sacrum to the tip of the ischial spine, sacrotuberous ligament connecting the sacrum down to the ischial tuberosity, and those then combined with the two notches on the pelvis create these fully enclosed greater sciatic foramen and lesser sciatic foramen. The other thing you can see in this anterior view of the pelvis with all of these ligaments added is that there's a very large ligament that lies anterior to the joint between the sacrum and the ilium. So the joint between the sacrum and ilium is called the sacroiliac joint, and it's covered anteriorly by this very large, very strong anterior sacroiliac ligament. So that helps hold the pelvis tightly to the sacrum. Little bit of an aside here, a little bit of a tangent. When I was working in the medical legal field, I had the opportunity on two different occasions to illustrate something called an open book fracture. So what happens in an open book fracture is that something basically compresses the pelvis from front to back, and it ruptures that pubic symphysis down here. It literally tears the pubic symphysis open, and also tears the anterior sacroiliac ligament, and the two halves of the pelvis open up like the front and back covers of a book, hence the open book fracture.
What would cause that?
So the one that I remember, I know I illustrated it twice. The one case that I remember vividly was there was a mechanic who was working for some sort of trucking or shipping company, and he was laying on his back working under one of the trucks. The lower half of his body was sticking out from under the trucks, and a forklift drove over him.
Oh, no.
So drove right over his pelvis and just, popped that pubic symphysis and opened up the sacroiliac, anterior sacroiliac ligaments, and just, opened up his pelvis like the pages of a book.
Like him suing somebody.
Yeah, I mean, it was a workers' comp case where he was suing for his injuries, suing the workers' comp insurance company for his employer, because you can imagine that's a pretty traumatic injury. And I remember also illustrating the surgical repair for this. They had to drill some big metal rods into some part of his pelvis. I can't remember where they drilled these rods. I think they were somehow in the front, like into the pubic bone maybe, or into the ASIS or something, and gradually pull the two halves of the pelvis back together. Like they had something on these metal rods that was pulling them together. The problem with that is you can't just put them back and then put a couple screws in and fix it, because there was also so much massive swelling of the soft tissues that you have to very gradually pull the two halves of the pelvis back as the swelling slowly subsides. And then once you finally get them back together, then you go put some wires in through the pubic symphysis and hold them together. Plus they put some big screws in through the ilium into the sacrum. to secure all of that together.
The second time that you had to...
I forget what the other one was. Some other kind of, I think it was a guy standing in front of a loading dock and a truck backed into him, if I remember correctly. Yeah. Well, right afterwards, zero. Right, so for the Zoom people, the question is, how much mobility do you have? Like right after the accident, you have no mobility, and probably for many weeks after, as the swelling subsides and as you try to pull the two halves of the pelvis back. Once they get the halves of the pelvis more or less back together, and they can put those wires in through the pubic bone and put the lag screws in through the sacroiliac joint, then you can probably walk. Again, I'm sure there's recovery time for the surgery itself, but probably get people back on their feet fairly quickly after the surgery. But so minimum of weeks.
I'm just thinking about how expensive that would be to fix.
Yeah, it's not a simple surgery. Yeah, very painful too, I'm sure.
Really bad.
All right. Same structures posteriorly. Greater sciatic foramen, lesser sciatic foramen, separated by the ischial spine and the sacrospinous ligament, and then this big sacrotuberous ligament connecting the sacrum to the ischial tuberosity down here. Now this ligament doesn't rupture. I mean, even in an open book fracture, this ligament won't rupture. I can't imagine any kind of injury that would rupture this posterior sacroiliac ligament, but you never know. There's all kinds of bizarre and interesting ways that people get injured. Maybe, although that would probably still cause the open book fracture if you're laying face down and get run over in the back, because it's that pubic symphysis is probably the weakest connection between the two halves of the pelvis. All right, so I mentioned earlier something called the pectinate line, which is this little ridge on the superior ramus of the pubic bone. And then also something called the arcuate line, which is a little ridge on the inner surface of the ilium. Those two ridges contribute to something called the pelvic brim, which is just this little ridge that basically runs all the way around the inner surface of the pelvis. And posteriorly, it's also continuous with what are called the ala of the sacrum, just meaning the wings, the lateral extensions of the sacrum. There's a little ridge on the ala of the sacrum up here. And even the very tip of the first sacral vertebra is known as the promontory of the sacrum. So all of these things combined form what's called the pelvic brim. So pectinate line, arcuate line of the ilium, the ala of the sacrum, and then that pointed promontory at the tip of the S1 vertebra. They form this brim, or this ridge that runs all the way around the pelvis. And this is significant because it's actually the dividing line between two different parts of the pelvic cavity. Sometimes the word pelvis is used not to describe the bones, but to actually describe the cavities sort of within the bones, the spaces between the bones. I'll try to use the phrase pelvic cavity instead of just pelvis, but in this terminology, which is very common in any anatomy book, they'll simply use the word pelvis, but they're actually referring to the cavity that's formed within the bones, not the bones themselves. So there's an area that lies superior to the pelvic brim, which I tried to shade in here in green. Didn't necessarily do a great job of it, but just took it into Photoshop, made a selection and slapped a green color on there, basically trying to show that there's part of the pelvic cavity that lies superior to this pelvic brim. This is known as the greater pelvis, or I guess you could say greater pelvic cavity, simply because it's the larger of the two parts of the pelvic cavity. It's bigger than the other part. So we use the word greater in this sense just to mean bigger. But it's also referred to as the false pelvis. Now that, I don't know, the first few times I read that, I thought that seemed counterintuitive. Wait a minute, it's greater, but it's also false. Doesn't greater mean better? Wouldn't that mean true? But not really. Remember, greater in this case just means bigger. It doesn't mean better. So it's called the false pelvis because really this part of the pelvic cavity is really just the bottom of the abdominal cavity. It's just the continuation of the peritoneal cavity down into the area between the left and right ilium. Yeah, Ben.
No, I was right.
Oh, I'm sorry. Okay. Okay, so it's the bowl that's formed by the left and right ilium. It's really just an extension, sort of the bottom of the abdominal cavity, and it's lies superior to that pelvic brim. So the other part of the pelvic cavity, shaded in pink, is known as the lesser pelvis. Again, not because it's less important, but simply because it's smaller. But it's also known as the true pelvis because this part of the pelvic cavity lies completely surrounded by the bones of the pelvis. So it lies between the pubis, the ischium, and the sacrum. And also, the true pelvis is not simply a continuation of the peritoneal cavity. It's its own separate space, separate from the peritoneal cavity. I think this is the better way of looking at it. I did try it on an anterior view too. I'm not sure that this is any better. I think it's actually doesn't work quite as well, but hopefully this helps you, number one, understand the pelvic brim, how it's formed by the pectinate line of the pubic bone, the arcuate line of the ilium, the ala of the sacrum, and then the promontory at the very front of the S1 vertebra, and goes all the way around to form this complete, more or less oval, separating the greater pelvis above from the lesser pelvis below. Okay, one last thing about the pelvis before we move on. There are a number of distinct differences between the male and female pelvis. And, you probably are aware of this fact. And of course, it's related to childbirth. So there are differences in the shape of the pelvis itself, and in particular, the shape of the pelvic outlet down here, which is basically where the birth canal would be. So in the female pelvis, the whole pelvis taken as a whole is quite broad, much wider, at least relatively wider than it would be in the male. In the male pelvis, the ilium especially is much taller and much narrower. Another really diagnostic tool, I mean, if you were ever to look at a pelvis and if for any reason, if you had to determine the gender of that pelvis, of course, this is something that forensic examiners have to do when they find bones out in the woods. They have to look at it and immediately know, okay, we're looking at a male or female victim. Of course, they can tell a whole lot more. They can tell not only gender, but also age and a lot of other stuff from the bones. But the subpubic angle, the angle formed between the inferior rami of the two pubic bones, if that angle is obtuse, meaning larger than 90 degrees, that's indicative of a typical female pelvis. Whereas in the male, it's a much tighter angle. It's an acute angle, less than 90 degrees. And then all of those things combine to create this difference in the size and shape of the pelvic outlet, where it's much more oval and wider in the female, much narrower, almost kind of heart-shaped in the male. So we're not going into lab today. Otherwise, I would say, take a look at the two articulated pelvises that we have in the lab and see if you can figure out.
Is it the plural?
Pelvis, yeah. Yeah. It's very rare that anybody ever needs the plural of pelvis, but if you ever do. I think most these days, probably most people would just say pelvises, which is probably perfectly acceptable. More trivia while we're talking about obscure Latin plurals. Anybody know the plural of octopus? Not octopi. Happened to our lights. That was weird. Well, a lot of people assume the plural of octopus is octopi because that's what it would be if it was Latin. The thing is, the word octopus is actually a Greek word. And so you had it right, Ben. It's octopodes. Yeah. I mean, these days, a lot of people just say octopuses, which is perfectly fine too, but that's sort of the English version. Anyway, that's your obscure, not really Latin, it's Greek. Your obscure science lesson for today. All right, so we've talked about the bones. Let's add some muscles to the pelvis. And of course, we've already talked about these, so I won't dwell on these. We've got quadratus lumborum connecting the iliac crest to the lower ribs. Got psoas major and psoas minor connecting the lumbar vertebrae, actually crossing the pubic bone to insert on the lesser trochanter of the femur. Iliacus originating from the inner surface of the ilium and also crossing over the pubic bone to have that same insertion on the lesser trochanter of the femur. Some other muscles, though, that we haven't seen before are things that we're going to see when we actually get down into the pelvic cavity itself. One that you will definitely see both inside the pelvic cavity, and also we'll see it again when we do the gluteal dissection. So when we go deep under the gluteus maximus muscle, it's a muscle called the piriformis. And it's a little hard to see here because it's covered by these large ventral rami of the sacral nerves. But hiding behind those sacral rami is the piriformis muscle. It's originating from the inner surface of the sacrum. And the muscle itself is actually going to exit the pelvic cavity by passing through that greater sciatic foramen that I was talking so much about before. So piriformis is originating from the inner surface of the sacrum, leaves the pelvic cavity by passing through the greater sciatic foramen, and eventually inserts on something called the greater trochanter of the femur. This muscle is actually a lateral rotator of the femur. So it's going to be hard for you because you can't see my feet. But if you can imagine, say, my right thigh here rotating, so my foot rotates away from the midline of my body, that motion is not happening down at my knee. It's happening entirely up here at the hip joint. So rotating the thigh so that the foot turns laterally away from the body, we call that lateral rotation of the thigh or lateral rotation of the femur, and it's happening at the hip joint. The piriformis is one of numerous muscles that are responsible for that motion. Another muscle that we'll have a little harder time seeing, we may not get a view of this one, but just be aware that it's in here. It's a muscle called the obturator internus. Now you remember I was talking about that obturator foramen, the big round foramen between the different parts of the pubic bone and the ischium in the front of the pelvis, and how most of that foramen is filled in with a tough membrane. And there's a muscle originating from the outer surface of that membrane and another muscle originating from the inner surface of that membrane. This obturator internus is the muscle that originates from the inner surface of the obturator membrane. So if you could remove the muscle, you'd actually see that obturator membrane here filling in the obturator foramen in the anterior part of the pelvis. So obturator internus muscle originates from the inner surface of that obturator membrane. It's also going to exit the pelvic cavity, and it's also going to insert on the greater trochanter of the femur. And it actually has the same role as the piriformis. It's another lateral rotator of the thigh or lateral rotator of the femur. The remaining muscles in the pelvic cavity are actually a group of muscles, but we usually talk about them all as being part of a single muscle called the levator ani. And if you think about that name, it's an elevator, it lifts up on something, and ani is referring to the anus. It actually can pull up on the anus, like when you kind of squeeze your butt cheeks and kind of clench all your muscles inside there, you can actually sort of lift up on your own levator ani. Or if you have to poop really badly and you're trying to hold it in, you'd be using your anal sphincter muscle, but you could also kind of use this levator ani to help kind of squeeze things together and try to hold stuff in. Besides things like that, the levator ani has one really, really important function. It keeps all of your organs from sliding out your butt. And, you know, I say that in a humorous way, but it's actually a real serious problem for humans, because if you imagine the transition from being a quadruped, walking on all fours, where all of your abdominal organs are basically hanging down in front of your belly, and now all of a sudden you stand upright, guess what? All your abdominal organs are pressing down into your butt. And the levator ani's job is to act kind of like a hammock and keep all of those pelvic and abdominal organs in the pelvis where they belong and keep them from sliding out your butt. It doesn't always work. There are conditions where you can have prolapsed pelvic organs. Probably the most common would be a prolapsed uterus, where the uterus can actually slide down the vagina and poke out of the outside of the body. The vagina basically turns itself inside out, and the uterus slides out through the pelvis, the bottom of the pelvis. The rectum can occasionally do the same thing. You can have a rectal prolapse, where the rectum basically turns itself inside out and kind of sticks out through the anus. Even the urinary bladder can prolapse. The urinary bladder can actually turn itself inside out and slide out the urethra. That's much more common in females because it would be very hard to get the urinary bladder to go through the penis and come out that way. But in the female, where the urethra is only like an inch long, it's much easier to do that. Yeah. Right.
What kind of situation would lead to that happening? So muscle action?
Yeah. So muscle weakness, which unfortunately is something that can be a consequence of childbirth. So the prolapsed uterus and prolapsed rectum can be things that can actually happen after childbirth, because the actual delivery process, you know, can dramatically weaken this muscle. Oh, you don't have to worry about origins insertions for levator ani. For these, no. Iliacus, psoas, same ones that you knew for the previous unit, you will. And by the way, with the next lecture, Tuesday after break, when we really start to get into more of the stuff in the lower limb, I'm going to give you a cheat sheet with all the muscles you need to know: origin, insertion, action, innervation. Yeah.
So these are paired, all three? So
yeah. Yeah, all of these things are paired. I mean, the levator ani basically creates one continuous sort of hammock or sling, but technically, yeah, there would be left and right ones.
You said you're going to give us that sheet after break?
Yeah.
Okay.
Yeah.
It'll be like a couple of days before the exam, right?
Oh, no, I mean, I'll give it to you literally the Tuesday after break, after Thanksgiving.
Thank you.
Because, I mean, I could have posted it now, I guess, but I have it with the first thigh lecture.
Okay.
You know, when we really get into the muscles of the lower limb.
Okay, thank you.
All right, so let's talk about the contents of the pelvis, because Monday after break, we're going to be looking at the contents of the pelvic cavity. So in both the male and female, the two major structures here in the pelvis are the urinary bladder and the rectum. Of course, in the female, you have the addition of the uterus and vagina that would lie between these, and I'll show you that in a minute. The urinary bladder lies immediately posterior to the pubic bone. In fact, you can almost think of the urinary bladder as sort of resting on the pubic bone, right up against the back of the pubic symphysis and the pubic bone. This illustration happens to be showing a fairly full bladder. You can see how it arches up into the peritoneal cavity a little bit, and it seems quite distended and rather full. If it were empty, it would be much more flat. It wouldn't have this big high dome. you might recall when we were talking about the gallbladder, I said that any organ that has kind of a rounded domed top has a fundus. So we do speak of the urinary bladder as having a fundus, which is just the rounded upper end of it. Of course, when it's empty, it's a lot more flat. It doesn't really have an obvious fundus when it's empty. The rectum sits immediately posterior to the urinary bladder, and in the male, the urinary bladder and the rectum are actually in contact with one another. In the female, the vagina would actually be in between the urinary bladder and the rectum, and then the uterus would sit up here above the bladder, and I'll show you pictures of that in a minute. Notice that in this picture, I've labeled the peritoneum. So you remember the peritoneum is the membrane that lines the whole inside of the peritoneal cavity or abdominal cavity. If you follow the cut edge of the peritoneum here in the anterior abdominal wall and follow it down into the pelvic cavity, you'll see that the peritoneum is laying on top of the urinary bladder. It's as if you've got this dome and you just sort of dropped a sheet on it. So that peritoneum covers the superior surface or that fundus of the urinary bladder. And then there's a little bit of an indentation here between the urinary bladder and the rectum. And then that peritoneum then goes up to actually cover the surface of the rectum as well, where it would be called visceral peritoneum, actually on the surface of the rectum. This is something I don't usually label these, and it's certainly not something I are going to test you on, but some anatomists, I don't know, really seem to pay a lot of attention to these little pockets, these little indentations that are formed within the peritoneum between organs. So in the male, you have something called the rectovesical pouch. Just refers to this little indented space here within the peritoneum that lies between the rectum and the bladder. The word vesicle or vesico is a prefix that you'll often see used in reference to the bladder. So this is the rectovesical pouch right here. Some other things that are unique to the male, obviously the testes down here in the scrotum, and we'll get a better look at these in our dissection on Monday when we come back from break. There's something called the epididymis, which collects all of the little seminiferous tubules from the testis. So the sperm themselves, the spermatozoa, are produced in a series of little tubes inside the testis called seminiferous tubules. Those all gather together in this thing called the epididymis. The epididymis lays sort of like a little hat on top of the testis, and then it dips down towards the bottom of the testis. And then it makes a sharp hairpin turn, 180-degree turn, and turns around on itself and starts to ascend up through the scrotum. And at this point, it's now called the vas deferens or ductus deferens. And that vas deferens or ductus deferens is going to run through the spermatic cord, through the inguinal canal, and then back here into the pelvic cavity, where it's going to run right along the fundus of the urinary bladder, all the way around to the very back of the urinary bladder. And then back here behind the urinary bladder, the vas deferens is going to join with an organ called the seminal vesicle, which is what's actually producing the semen fluid, the seminal fluid that makes up a lot of the volume of the actual semen. So semen itself, the ejaculate, the male ejaculate, is a mix of the sperm cells themselves that have migrated up from the testes, plus this seminal fluid produced by the seminal vesicles. The vas deferens and the seminal vesicle join to form something called the ejaculatory duct, which is not shown on here, but I think it's shown on the next slide. The ejaculatory duct then enters into the prostate gland, which sits just below the urinary bladder. The urethra, which is carrying urine from the bladder to the outside, is originating from the urinary bladder, passes right through the middle of the prostate gland, and then out through the penis, out to the tip of the gland's penis. So that ejaculatory duct formed from the junction of vas deferens and seminal vesicle that is joining the urethra here inside the prostate gland. And again, we'll see a better picture of that in just a minute, a cross-sectional view. So the urethra is actually carrying, in the male, of course, it's carrying the urine from the bladder, but it's also carrying the semen from the vas deferens and the seminal vesicle. And last thing shown on here are some erectile muscles. So as the name implies, these are muscles that are involved in producing an erection. And I'm not going to test you on their names, but they are things that you may encounter, in your future as medical illustrators. So you might want to just recognize they have these crazy sounding names, the bulbospongiosis and the ischiocavernosus. I think when people find out that there are muscles involved in erection, they have this perception that, oh my gosh, there are muscles sort of yanking on the penis and lifting it up, like a cable on a crane, hoisting a crane or something like that. And of course, they don't do that. The erection is formed entirely through the accumulation of blood in the erectile tissue of the penis. So we'll see in a minute the erectile tissue. And there's two different kinds of erectile tissue. There's the corpus cavernosum and the corpus spongiosum, and these two muscles are associated with those two different types of erectile tissue. There is blood constantly flowing into the erectile tissue, which is basically like a sponge. And under normal circumstances, there's blood flowing out of the erectile tissue at the same rate. For an erection to happen, these muscles actually clamp down on the veins, leaving the erectile tissue, compress those veins, so blood continues to flow into the erectile tissue through the arteries, but it's got no way to get out because these muscles are compressing the veins, so blood accumulates in the erectile tissue, leading to the formation of an erection. So on Monday, when you come back from break, you get to add another thing to your list of weirdest things you've ever done in your life. We are going to literally saw the pelvis in half. So we're going to saw through the pubic symphysis. We're going to saw through the entire sacrum, right up into the lower couple of lumbar vertebrae, and actually then make a transverse cut, a sideways cut, and completely remove one of the lower limbs. So in each half, the part that's still connected to one of the lower limbs and the part that's connected to the rest of the body will be roughly a mid-sagittal cut section through the pelvic cavity. And so we'll actually be able to see a lot of these structures that you see here in that sagittal cut section. So you'll definitely be able to see the pubic symphysis, which of course is shown here in blue because it's a cartilaginous joint between the two pubic bones. The urinary bladder rests right posterior to that pubic symphysis, resting on the pubic bone. The wall of the urinary bladder consists of a muscle known as the detrusor muscle. I think there's another common misconception that when people urinate, they simply open the sphincter, basically open the valve, and under gravity, the pee just flows out. Just like, taking a bottle and turning it over and just dumping liquid out. But it doesn't work that way. You actually have to force the urine out. This muscle in the wall of the urinary bladder, called the detrusor, actually has to contract and push the urine out. That muscle is under control of the parasympathetic system. So urination is a parasympathetic function. The ureters, remember the ureters are the things that come down from the kidneys, bringing the urine from the left and right kidneys into the urinary bladder. The ureters open by way of a pair of small orifices into the interior of the urinary bladder. Then the urine leaves the urinary bladder through the urethra. So make sure you keep those two words straight. Ureter, the tubes carrying urine from the kidneys to the urinary bladder, and urethra, the single tube carrying urine out of the urinary bladder to the outside. In the male, this urethra is quite long because it's going to pass down from the urinary bladder through the center of the prostate gland. And then it's actually going to travel through the center of one of the parts of the erectile tissue of the penis. It's going to travel all the way out to the tip of the glands of the penis to eliminate urine, from the body. So the prostate gland itself is shown here in cut section. You see how the urethra passes right through the center of the prostate gland. And then just posterior to the urinary bladder, we have the seminal vesicle. So I mentioned in the previous slide that the vas deferens joins the seminal vesicle. Together, they create something called the ejaculatory duct, which is not labeled on here either, but it will be eventually. There is a label that shows the ejaculatory duct. So that ejaculatory duct, you can just kind of barely make it out right there, passing from the seminal vesicle to join the urethra in here. And then, as I said, the urethra is going to pass through the erectile tissue of the penis. So the urethra actually is surrounded by one portion of erectile tissue called corpus spongiosum. This runs along the inferior edge of the penis, but then enlarges at the tip of the penis to form the glans or the head of the penis. And then sitting on the top surface, or really, technically, this is what's known as the dorsal surface of the penis, we have a larger region of erectile tissue called corpus cavernosum. They're both basically just spongy, blood-filled tissues, but the microscopic structure of the spongiosum and the cavernosum are a little different, so hence they get different names. You can then, posteriorly, you see the rectum back here, leading to the anus, surrounded by the anal sphincter, which helps to hold the poop in. Oh, and I didn't mention this. I have a better slide, I think, that shows this better. There's something called the trigon. Most of the interior of the urinary bladder is very wrinkly, but there's this one smooth area that lies between the left ureter, the right ureter, and the opening into the urethra. So that triangular area between those three orifices is known as the trigon. If you look at this Netter painting, notice that the urinary bladder appears to be fairly large and hollow. In this case, it's empty. There are a lot of bad illustrations of the urinary bladder showing the relationship of the urine to the interior of the urinary bladder. And I think this reflects this misunderstanding that people think you just basically open the valve and the pee just drains out. But it doesn't really work that way. So when the urinary bladder is completely full, as we see here in the upper left, that urine should literally fill the interior of the bladder. It should completely fill all of the space inside the urinary bladder. When someone urinates and they empty their bladder, the pee doesn't just drain out, leaving the urinary bladder as a big hollow vessel. The detrusor muscle in the wall of the urinary bladder actually has to contract and compress in order to squeeze the urine out. So in a roughly empty bladder, the interior space in the bladder is going to be completely obliterated, completely compressed. And that muscle is going to contract in a way that the whole bladder kind of flattens out and gets compressed. Now, sometimes, as with the previous picture, the Netter painting, you can show the interior of the urinary bladder as being empty, but in this case, the artist is using a little artistic license and basically saying, okay, I'm drawing the urinary bladder as if it were full, but I'm simply going to remove the urine so we can see the interior of the wall of the bladder. What you should never do is this in the bottom right, and show the urinary bladder as if it's full, but only show it half full of urine, as if the urine has simply drained out, leaving this large hollow chamber there. I remember going to a lecture at one of the AMI meetings where they were talking about this misconception, this inaccurate illustration, and they described the urine as looking like a lake, and they actually painted a little tiny sailboat in there, sailing on this urine lake inside the urinary bladder. And I can openly admit that I've made this mistake. I mean, I drew all of these, and I drew this one wrong for some book once. And I can also admit that that's because I literally never thought about it and didn't catch myself that, ooh, I'm drawing this wrong. We do have a former student who works at the Roswell Park Cancer Center in Buffalo. No, actually, she used to. She moved to another job just recently. But anyway, when she was working for the Cancer Center, they illustrated a book all about bladder cancer. And so, as you might imagine, there were lots and lots of illustrations of bladders in there. Oftentimes, they had urine in them. And they drew lots of pee lakes, like this one. And I remember talking to Yana about that, and she said, oh, yeah, we knew it was wrong, but the doctor insisted. It's like their boss insisted that they draw it that way, even though the boss knew darn well that it wasn't accurate, only because it was directed towards lay people, and they didn't think that the lay person would really understand how the bladder worked. So they actually intentionally wanted to lie to people and show the little urine lake in a half full bladder. So I don't know that I necessarily agree with that reasoning, but when your boss tells you to draw it a certain way, you draw it a certain way. All right, so here is basically a coronal or frontal cross-section through the bladder in the male with then some of the associated organs here. So here we see a cutaway into the urinary bladder with the orifices for the left and right ureters coming down from the two kidneys, the orifice for the urethra down here where the urine's going to drain out of the bladder, and then a triangular area formed by those three orifices called the trigone, which should be the only part of the inside of the bladder that's smooth. And you see how the urethra then enters the prostate gland, and there are actually openings for the prostate itself. The prostate produces a liquid that helps to it helps nourish the sperm cells themselves, the spermatozoa. I think it contains a sugar. Is it glucose or fructose? I don't know. There's some sugar that's in there, but also helps to balance the pH of the semen. So there are little orifices for the prostate itself to secrete its fluid into the urethra, but then also a couple of openings for the ejaculatory duct. So that's where the vas deferens and the seminal vesicles join together. So the urethra then continues farther down and enters the corpus spongiosum, which is the smaller piece of erectile tissue. That in turn is surrounded by the corpus cavernosum, the larger bit of erectile tissue. There are also a couple of little glands in here called Cowper's glands or bulbourethral glands. These produce a sort of a lubricant that is emitted by the penis during sexual arousal. And here's an inferior view. So looking up at the penis from below, obviously with all of the skin removed, just to show the relationships of the different parts of the erectile tissue. So the urinary bladder would be entering the corpus spongiosum, excuse me, not urinary, the urethra would be entering the corpus spongiosum back here near the bulb, and then the urethra travels right through the very center of the corpus spongiosum all the way out to the tip of the glands. And then the corpus cavernosum sits on the dorsal surface, so what would be the top of the penis if it were erect, and if somebody were standing upright. I've always thought it looks like a hot dog in a bun, but if you imagine it the way it would sit in the body standing upright, it's an upside down hot dog in a bun.
This isn't really related, but is there a different pH in men and women for urine?
I don't know about urine. I thought you were going to ask, is there a different pH between the vagina and semen. Yes,
Yeah.
there is. The semen is more alkali. I remember that. But urine, I don't think so, because they're all produced by the same physiology through the kidneys.
Mhm.
And I don't think that passing through the longer urethra in the male, you know, I don't think there's enough interaction with any of the other fluids that it's going to like noticeably alter the pH.
Does the semen then change the pH of the vagina?
Yeah. Yeah, the difference in pH is designed to actually make the vagina more hospitable for the sperm to survive.
Thank you.
Yep. All right, so moving on to the contents of the pelvis in the female. Of course, some things are obviously going to be the same, and then there's going to be some obvious differences. So we've got the urinary bladder again, resting on the pubic bone, just behind the pubic symphysis, with that layer of peritoneum sort of draped over the fundus of the urinary bladder. Then we've got the rectum posteriorly, again with peritoneum draped over it. But then you have the vagina, which is basically a muscular tube, which is sandwiched in between the urinary bladder and the rectum. And then there's a sharp angle, typically about a 90-degree angle between the vagina and the body of the uterus itself. The uterus then turns sharply anteriorly and actually rests on top of the urinary bladder. And there are conditions where the uterus can actually tilt too far forward or may tilt back a little bit. There's what's called anteversion and retroversion, where the uterus can either tilt a little farther forward or a little farther backward. I think sometimes those have implications for fertility, because the angle at which the uterus meets the vagina can actually influence whether the semen can actually get up into the interior of the uterus or not. One thing that's a little hard to tell here, but I want to point it out to you, is remember I was talking about how that layer of peritoneum lies over the fundus of the urinary bladder and how it also covers the rectum. Well, in the female, it covers the uterus as well. So imagine that you've got your urinary bladder is basically a dome, and then you've put another object on top of the urinary bladder, and then you drape a sheet over all of that. You can actually see how that layer of peritoneum reflects off the urinary bladder and then up over the uterus, back around the back of the uterus, and then back to the rectum again. So it's as if this sheet is completely draped over the body of the uterus. And we'll come back and talk about that more in a bit, because there are some structures that essentially function as ligaments to help support the uterus within the pelvic cavity that are derived from these layers of peritoneum that cover the uterus. The other thing to notice here is that the uterine tubes branch off of the body of the uterus, and they actually run a little bit posteriorly and somewhat superiorly. They're actually following the pelvic brim. Remember, the pelvic brim is that series of ridges formed by the pectinate line of the pubic bone and the arcuate line of the ilium. The uterine tube is following the curvature of that pelvic brim. And then the end of the uterine tube wraps around, and the ovary is kind of surrounded by the uterine tube, with the end of the uterine tube kind of wrapping around and embracing the ovary. At the tip of the uterine tube are these little finger-like projections called the fimbria. And those are the things that basically grab the ovum from the surface of the ovary during ovulation. By the way, I've been using the term uterine tube. This is another little bit of a change in anatomy. I've mentioned before how anatomists are trying to get away from things that are named after people. So Fallopi was another Renaissance Italian anatomist. And so for generations, everybody's been calling this thing the fallopian tube, but not realizing that that's actually named after somebody. So these days, I think more anatomy books are actually referring to it as the uterine tube instead of the fallopian tube. Before I move on, well, let me finish this up first, and then I'll come back and talk a little bit more about the position of the uterus. So the clitoris is the more or less equivalent or homologue of the penis from the male, and it consists of the same types of erectile tissue that you find in the penis. There is a corpus cavernosum and a corpus spongiosum. The clitoris is made up predominantly of the corpus cavernosum. The spongiosum is less important in the erection of the clitoris. And the same muscles are present, ischiocavernosum and bulbospongiosus. And they have the same role in clamping down on the venous outflow from those areas of erectile tissue to cause engorgement or erection of the clitoris. All right, so let me come back and talk a little bit about the position of the uterus, because this is one of the things that is probably drawn inaccurately more often than just about anything in anatomy. And I don't know, for the benefit of those of you watching on Zoom, let me see if I can get, if you can see me or not. Yeah, okay. So there are so many bad, inaccurate pictures of the position of the uterus and the position of the uterine tubes and the ovaries. My personal favorites are the Batman uterus. So uterus standing straight up, uterine tubes out to the sides, and oh, let me grab my ovaries. I got the ovaries out here like this to the side. Yes, I did. And remember, I was talking before about how the peritoneum drapes over the uterus, sort of like dropping a sheet over it. So when Batman's standing like this, he's holding his cape off to the side. So that would be this thing called the broad ligament, which is basically the mesentery, the folds of mesentery on either side of the body of the uterus. Problem with the Batman uterus is that the uterus does not stand straight up and down in the pelvic cavity. And the uterine tubes do not stick straight out to the sides like this. So my other favorite wrong, inaccurate depiction of the uterus is what I call the touchdown uterus, right? So same thing where the uterus is standing straight up and down. Uterine tubes are up like this with the ovaries in the front. Of course, you know, when the referee signals touchdown on the sidelines in a football game, they're not holding ovaries, but still, you know, they're in that position. And that's wrong for a couple of reasons. Again, the biggest inaccuracy with that is the fact that the uterus is standing straight up and down. Look at the orientation of the uterus in this picture. The body of the uterus is laying on the urinary bladder. Remember, any organ that has a rounded dome, it's called a fundus. The fundus of the uterus is pointing straight ahead, anteriorly. And I gotta readjust my camera here for the benefit of those at home. And I gotta do this in a way that I don't fall over and hurt myself. So I'm a uterus. So it is, unfortunately, and I did hit record. I think I did. My legs are a vagina. How about that one? You want a ridiculous thing to record. So, all right, please don't hurt myself. So I'm doing that because the vagina is not straight up and down either. The vagina slopes posteriorly at an angle, kind of like my legs. And then the body of the uterus does this, right? It's laying flat on the urinary bladder. And conveniently, I have a fundus of my own up here. facing directly towards you. And then the uterine tubes actually go up like this around the pelvic rim, and the ovaries are behind the uterine tubes. So from this view, you shouldn't be able to see the ovaries. They're hidden by the uterine tubes, and you can't see any of the body of the uterus. All you can see is the top of the fundus. Right, so I managed to successfully do that and not hurt myself.
That's representation of the vagina.
Right. All right, we'll come back to that a little bit. I won't do the impression again, but we'll come back to that a little bit more. So here's the mid-sagittal section. So this is going to be more similar to what you're going to see when we do the cut section of the pelvis after break. So again, we've got pubic symphysis down here, urinary bladder resting right on the back of the pubic symphysis and the pubic bone. Now notice in this case that Netter has painted this urinary bladder as being primarily empty, whereas in the male, for whatever reason, he drew it full, although in both cases, he's actually removed the urine itself. But you can see how collapsed and compressed the detrusor is, the detrusor muscle is. Whoopsie. And the vagina, this angled muscular tube lying between the urinary bladder and the front of the rectum, and then how the body of the uterus tilts forward with the fundus facing directly anterior, and then the uterine tubes extending up along the pelvic brim and kind of encircling the ovaries. By the way, the cervix is the inferior-most part of the uterus, which extends down into the vagina. And you may be able to tell that depending on the angle between the uterus and the vagina, the position of the cervix is going to be different, which can influence the ability of sperm to actually get up into the cervix. So believe it or not, this is like the best and only picture I have ever been able to find of the structure of the erectile tissue in the female. So apparently it doesn't get nearly the same attention that the erectile tissue of the penis gets. Probably if you want to make yourself some money, go out and do a better illustration of the erectile tissue in the female. So there is a vestibular bulb, which is comparable to the corpus spongiosum, but most of the clitoris is formed actually from the corpus cavernosum, which forms these two legs or crura, and then they join together and form the glans, which has its own little prepuce or little sort of covering over it that lies just a little bit anterior to the opening of the urethra and the vagina. Now here's a Batman uterus, but it's a Netter painting, and I know that he knew better. He used artistic license, and he intentionally stood the uterus up like this inside the pelvic cavity. You can see he's even got some instruments that he's painted in here holding open the walls of the vagina. So I'm pretty confident that he knew that the uterus doesn't normally sit in this position, but he moved it into this position on purpose so that you can actually see a coronal cut section into the interior of the uterus. The problem is that I think then a lot of people just copy this and they'll actually draw the uterus sitting inside the body in this Batman position. So we've got muscular tube of the vagina, the cervix that protrudes down into the vagina a little bit. There's a narrow neck of the uterus, and then it gets much wider, forming the body of the uterus, which has a lumen or space inside of it. Fundus, of course, the rounded dome at the top, or really technically the front of the uterus because it's facing anteriorly in normal position. The opening inside the body of the uterus then leads into the interior of the uterine tubes, which actually do change diameter pretty significantly along their length. And out at the ends of the uterine tube, you have the fimbria, the little finger-like projections. The ovary itself is actually anchored to the body of the uterus by an ovarian ligament. We'll see in a minute that there's another ligament that also attaches to the body of the uterus. So here you see another Netter painting showing the uterus, but this time more in its sort of natural position in the pelvic cavity, with an emphasis on these layers of mesentery that form a series of folds over the body of the uterus, as well as some of the structures that extend out from the sides. So, and in this case, you can really tell that Netter knew that the uterus doesn't normally sit in this position, because he actually put an instrument in here, a forceps, actually grasping the fundus of the uterus to tilt it up into this position. So that's sort of his signal that, yeah, I know it's not normally in this position. We're literally grabbing it and pulling it up into this orientation. So there are a pair of round ligaments that extend off the anterior part of the body of the uterus. Remember, this is the remnant of the gubernaculum. So in the male, that's the thing that anchors the testis inside the scrotum. But here in the female, it forms the round ligament, which is going to extend up through the inguinal canal. Just lateral to that is the uterine tube itself, continuing out to the fimbriated end. And then the ovaries are anchored to the body of the uterus by an ovarian ligament that we saw in the previous slide. Now, again, thinking about that peritoneum up in the abdominal cavity, that layer of peritoneum is then draped over all of these structures, again, just sort of like dropping a sheet on top of the body of the uterus with all these various things projecting out. So there's a layer of peritoneum that drapes over the fundus and the body of the uterus, so we would call that visceral peritoneum, because it's covering an organ. But then that same layer of peritoneum forms a fold as it drapes over the round ligament. It forms a little fold or a little flap. And then that same layer of peritoneum is also then draped over the uterine tube. So imagine if I had my arm sticking out to the side and I literally just draped a sheet over that on the front and the back. That's what forms something called the broad ligament, which is one of the main suspensory ligaments that helps hold the uterus within the pelvic cavity. And the uterine tube itself actually has an extra little flap of mesentery known as the mesosalpinx. It's another one of my favorite anatomy names. Meso referring to the fact that it's basically mesentery, and salpinx being a Greek word for tube. Yeah.
2 slides back.
Okay.
The Batman uterus.
This one?
Yeah.
Yeah.
So is that just perspective with the fallopian tubes being that large, or are they actually that much larger than the uterus?
Good question. Yeah, I mean, most of the length of the uterine tube is pretty tiny. Okay. But they do flare out quite a bit out towards the fimbria, out at the end. Okay. So it's probably pretty close to scale. It looks like the diameter, or I guess, yeah, the diameter of the fibria is like almost the same as where the cervix of the uterus. Yeah. Yeah. That's pretty accurate. I think that is pretty accurate. Yeah. Thank you. Sure. Just, yet another picture showing the position of the uterus in the pelvic cavity. So this is a top-down view. So we're looking down into the pelvic cavity from the abdomen. So you got urinary bladder resting on the pubic bone, body and fundus of the uterus resting on the urinary bladder with the fundus pointing straight ahead towards the front. These round ligaments running from the body of the uterus up towards the inguinal canal. The uterine tubes running sort of posteriorly, but you can't really tell that they're sitting at an angle as they run along the pelvic brim, and the ovaries kind of surrounded by the uterine tubes, and then all of this stuff draped with this layer of peritoneum. Okay, I know we're going over time, but you don't have another class after this, so I kind of have your attention for like 2 more minutes. Yeah, really. Oh, okay. Last thing I want to mention here are the arteries in the pelvic cavity, because this is one of the key things you're going to be looking at on Monday in Monday's lab after we come back from break. So we're looking at a mid-sagittal cross-section through the pelvis. So you've got the last 2 lumbar vertebrae up here, a little bit of L4, L5, and then all of the sacral vertebrae and the coccyx way down here, and then pubic symphysis over here in the bottom right. The way this particular cut section was made, you can see the aorta and then the right common iliac artery is cut off and the right common iliac vein is cut off. So after the bifurcation of the aorta and the IVC. But what we're seeing here then is the left common iliac artery and left common iliac vein kind of receding away from us into the left half of the pelvic cavity. Each common iliac vessel is then going to split into external iliac and internal iliacs. So there's going to be an external iliac artery and also external iliac vein, which are going to cross the pubic bone and enter the thigh, at which point they change names to become the femoral artery and femoral vein in the thigh. We're focused mainly on these internal iliac vessels. So internal iliac artery and vein. We're going to just remove the veins in our dissection, and we're just going to focus on the arteries because the veins have the same branching pattern and the same names. So the internal iliac artery itself may be relatively short, and then it's going to very quickly start giving off a bunch of branches. Probably the first branch you're going to find is something called the superior gluteal artery. This is usually by far the largest branch off of the internal iliac. And it usually has a very specific relationship to some of the nerves inside the pelvic cavity. There's something coming down from the lumbar spine called the lumbosacral trunk. Those are the ventral rami of L4 and L5. And then there's a nerve over here, which is the ventral ramus of S1, the first sacral nerve. The superior gluteal artery is very large, and it typically is going to pass right between the lumbosacral trunk and S1. So that's usually a pretty good landmark to find superior gluteal artery. By the way, this superior gluteal artery is exiting the pelvic cavity through the greater sciatic foramen, along with the piriformis muscle and a whole bunch of other things. All right, so going back to the rest of internal iliac, the other branches you'll be looking for include the obturator artery. And I know this one is surprisingly hard to find. It looks like it should be pretty obvious. It should be right there, but I think the problem with finding obturator is that sometimes its origin can be fairly variable. It may even branch off the superior gluteal. But the trick to finding obturator artery is to find the obturator nerve. And if you see an artery joining the obturator nerve, and both of them are passing through that little obturator canal, then you can be pretty sure that's obturator artery joining the nerve. Another artery branch, which is usually quite easy to identify, is the umbilical artery. Now that artery is going to branch off of internal iliac, and it's going to head towards the anterior abdominal wall. And most of it, or part of it, still functions as a real artery and gives off branches to things like the urinary bladder. But then the rest of the artery flattens out and becomes a white ligament. There are two of these, one on the left and one on the right. These are remnants of the actual umbilical artery that brought deoxygenated blood to the umbilical cord during fetal development. So remember, there was one big umbilical vein that brought oxygenated blood from the placenta back to the baby, and that passed into the liver. That's that becomes the ligamentum teres after birth, going right into the liver. But there are actually two arteries carrying deoxygenated blood out of the fetus to the umbilicus. So you can actually follow the white obliterated part of this artery right up along the inside of the anterior abdominal wall, all the way up to the umbilicus. But that whole part is just obliterated. It doesn't function anymore. The other branches that you'll identify, we're not going to try to identify all of the uterine, the vesicle branches. The vesicle supplies the urinary bladder, rectal arteries. So those are pretty variable. So we're really only looking for two others. The final split of the internal iliac is between the inferior gluteal and internal pudendal arteries. Both of these are also going to exit the pelvic cavity through the greater sciatic foramen. And we'll pick them up later when we look in the gluteal area and see what becomes of them. Right now, I think I lied. I think we maybe have one more slide, but you've already seen most of this. So we've already identified subcostal, iliohypogastric, and ilioinguinal nerves coming from L1, lateral femoral cutaneous nerve coming from L2 and L3, femoral nerve and obturator nerve coming from L3 or 2, 3, and 4. But and then here's the obturator nerve actually coming through the obturator canal, through the obturator foramen. But one new nerve that we still won't actually see very clearly, even in the pelvis dissection, but we'll definitely see it when we do the gluteal dissection, deep in the gluteal area, is the sciatic nerve. So sciatic nerve combines the lumbosacral trunk coming from L4 and L5 with the ventral rami of S1, S2, and S3. All of that joins together to form this gigantic nerve called the sciatic nerve. It's about as big as your finger, and largest nerve in the body other than the spinal cord. So you might just barely be able to see where lumbosacral trunk joins S1 and S2 and S3. But the sciatic nerve, by the way, is yet another thing that is leaving the pelvic cavity through the greater sciatic foramen, and continuing into the gluteal area, deep to the buttocks. Okay, is still not the last slide. Anyway, just showing the same stuff from the inside. So this is what it's going to look like when you dissect these things. You'll see those arteries. You see L4 and L5 joining S1, S2, and S3, all of that together to form the sciatic nerve, which is then leaving the pelvic cavity along with all of this other stuff, all these arteries and the piriformis muscle all exiting the pelvis through the greater sciatic foramen. All right, is that finally it? Yay, okay.
Recorded lecture.
Well, it's recording, so it's in my courses. Yeah, of course.